Welcome to the Johns Hopkins Medicine online webinar series. Today, Dr. Risa Wolf and our diabetes educator, Maggie West, will be speaking about recent advances in pediatric diabetes care, diabetes technologies. Before we get started, we'd like to provide some user tips so that you are comfortable using this platform. The first 30 minutes of our program will include an informative presentation by our presenters. The last 30 minutes will be dedicated to our live Q&A session. Please note this program is being recorded. To submit a question, please type your question into the Q&A box and click send. Your questions will be seen by others watching this presentation, so please note if you do not want your name attached to your question, please check send anonymously. Also, your email address will not be shared with any third parties. We will do our best to answer all questions we receive during the Q&A session. Alternatively, you can email us questions and feedback to hopkinsseminars@jhmi.edu. At the end of the webinar, we would greatly appreciate receiving your feedback and ask that you complete our survey. And now I would like to welcome Dr. Risa Wolf and our diabetes educator, Maggie West, to begin our presentation.
Good morning, I'm Risa Wolf. I'm a pediatric endocrinologist at Johns Hopkins with a focus on pediatric diabetes care. And Maggie West, who's our lead clinical nurse, will be presenting along with me. Today we're going to talk about recent advances in pediatric diabetes care with a focus on diabetes technologies. Today I'm going to start by giving an overview of type 1 and type 2 diabetes in pediatrics, management of diabetes in children and adolescents, and then we're going to turn over to the technology landscape, talking about insulin pumps, sensors, and the newest hybrid closed-loop systems and what's coming out in the near future. So we've come a long way in the management of type 1 diabetes. In the old days, before we had blood glucose monitors, people would smell their urine to see if it smelled that there was sugar in it. The development and discovery of insulin in 1923 was a landmark in the treatment of type 1 diabetes, such that children were able to be treated and survive with a diagnosis of type 1 diabetes. Move forward to the 1960s when the first insulin pump was made, and back then it was worn as a very large backpack, very different than the insulin pumps we know of today. Testing on insulin pumps began in the 1970s, and by the 1980s, it was considered an alternative form of insulin delivery for patients with type 1 diabetes. Now we have much smaller insertion sites, much smaller devices, continuous glucose monitors, and this is a picture of another insulin pump that is tubeless. And we'll talk a little bit more about these technologies shortly. So I just want to give a little bit of background to pediatric diabetes and what it looks like today compared to 10, 20 years ago. So type 1 diabetes is one of the most common chronic childhood diseases. Interestingly, the incidence has increased by over 21% over the last decade for reasons that are not totally clear, whether there are some environmental or genetic component or immunologic component is not totally clear. But at this time, the prevalence is about 1 in every 500 children. Contrast that with type 2 diabetes, which essentially 20 years ago was unheard of in pediatrics. Now, in the adolescent population, is approximately 50% of new onset diabetes in that age group in adolescents. And this prevalence is highest in American Indian youth, African American youth, and Hispanic youth, much more so than non-Hispanic white youth. The incidence of type 2 diabetes has increased by over 30% over the last decade. So as you know, the goal of pediatric diabetes care is to maintain a hemoglobin A1C level, which is a marker of your glycemic control over a period of approximately 3 months, to maintain an A1C of less than 7.5%. For type 2, this goal is even lower. And the reason why we set this as a goal is because we know, based on the Diabetes Control and Complications trial that closed in 1993 and was published in the New England Journal of Medicine, that if you maintain tight glycemic control, you can prevent the complications and the long-term complications of diabetes. So that means that when we set a goal of less than 7.5%, we're aiming for a blood sugar average of about 150 to 180, which is in this range over here. And in preventing the long-term complications, that pivotal trial, which has really shaped the way that we treat diabetes from there on, is that the intensive insulin therapy using a basal bolus insulin regimen, which I'm going to talk about in a minute, delays the onset and slows the progression of diabetic retinopathy, nephropathy, and neuropathy. So retinopathy being the ill effects on the eye, leading to retinopathy and potentially vision loss and blindness, reduces that risk by 76%. For nephropathy, reduces by about 50%, and neuropathy by 60%. So given that we want to accomplish this, we set glycemic targets at less than 7.5%, and it's truly our treatments and technology that help us reach these goals. So I want to share with you the current state of type 1 diabetes. This was published last year by the T1D Exchange Group, which has multiple centers around the country and is a representative sample of type 1 diabetes in the nation. And you can see on this graph that the orange line is actually the data from 2010 to 2012. And the blue line is more recent data from 2016 to 2018. And what you can see in this table is that in the children's age 0 to 20, we have the highest hemoglobin A1C levels, speaking to the challenge of daily diabetes management in children with type 1 diabetes. The unfortunate part is that over the last few years, we have seen an increase in these average levels, and we think that that is likely due to the increasing in the obesity epidemic and is likely contributing to the worst glycemic control. But what you also can see here is that in the 10 to 20 age range, which is our typical adolescent population, they unfortunately have the worst glycemic control, or the most difficult patients to manage. Of course, that is our specialty and what we love to do and try and help these children. This just shows you the trends in the childhood and adult obesity in the United States over the last essentially 20 years. And you can see that in youth, there's been an increase in obesity, and that's where we've seen this concurrent increase in type 2 diabetes. And there's been an annual relative increase of approximately 5% per year in type 2 diabetes, which is really tremendous compared to 20 years ago. So now I'll move on to talking a little bit about diabetes management and these basal bolus insulin regimens that I prior described. So we use two types of insulins in achieving this sort of regimen. We use a long-acting or basal insulin, which basically covers your background insulin needs. Generally, it's a medicine you take once a day. It's an injection. These come in the form of insulin glargine, which is Lantus or Basaglar, Detamir, which is Levemir, or Degludec, which is Tresiba. And these medications typically last for 12 to 24 hours. And generally in pediatrics, we dose them once a day or every 24 hours. The alternative to using a long-acting basal insulin is using an insulin pump, which we're going to talk much more in detail about. And here we set a basal rate using short-acting insulin that basically covers your basal insulin needs. We combine that with short-acting insulins, which are such as insulin Lispro, Aspart, Glulicine. These are Humalog, Novolog, Aspart, Admelog. These generally start working within 10 to 15 minutes, and they last up to 4 hours. These are considered prandial insulins. They cover the carbohydrates that you eat at meal, and they cover your high blood sugars in order to correct those blood sugars down to a normal level. So this is just a schematic of how these basal bolus insulin regimens work. And essentially, this red line across the figure is the basal insulin. And we set a basal insulin dose that you get every day, and we dose it every 24 hours, as close to 24 hours as we can. And this essentially covers your background insulin needs for when you're fasting, when you're sleeping overnight. When you eat, we give bolus insulin or prandial insulin, which is the dose is determined based on your blood sugar at the time and your carbohydrate intake. So it's a little complicated because you do have to calculate this at every meal. And the calculations are based on a insulin to carbohydrate ratio that we help you set, as well as a correction dose or correction factor. There are several names for this correction dose and factor that are different for every insulin pump. And definitely people use different language in saying it, but it's correction dose, correction factor, insulin sensitivity factor. The short-acting insulins, these bolus insulins, begin working in 15 minutes, and they peak about 30 to 60 minutes into their use, and they last for about 3 to 4 hours. And that's why they're ideal for breakfast, lunch, and dinner. The basal bolus regimen offers a lot more flexibility compared to some of the older regimens with some of the MPH insulins and regular insulins that we used to use before these newer agents were created. And the flexibility means that as long as you have your basal insulin on board, whatever time your meal is, you can take your insulin at that time. It's not a fixed meal time as it used to be with other regimens. So you can eat anytime on your schedule. It doesn't have to be set at 8, 12, and 6. It can be if you want to have a late breakfast on the weekend, it can be at 11. And you basically can cover any amount of carbohydrates that you take, obviously while maintaining a healthy, balanced diet. We always recommend checking your blood sugar before all meals and snacks, which comes out to be at least 4 times per day. So those regimens require at least 4 injections per day, which for a child can be traumatic in the beginning. And hence the development of these very small insulin pumps, which provide an alternative to a basal bolus insulin regimen using injections. You can use a pump, which is a small computerized device that delivers rapid-acting insulin to cover both your basal and bolus insulin needs. And it's a way to mimic what the healthy pancreas does, similar to the basal bolus regimen, but a little bit more, with a lot more flexibility. So these are just some of the pump components that come with an insulin pump. You have the cartridge that holds the insulin. This goes inside of the pump. The cartridges generally for the pumps that we use today carry as much as 200 to 300 units of insulin, and you wear them for 3 days at a time. The infusion set, they're even smaller now than when this slide was created, but they're very small. They just leave a very small catheter, like a little straw, underneath the skin to infuse the insulin from the pump. And then the pump has all of the programmed doses in it, such that you just have to tell the pump, I am eating this many carbohydrates and my blood sugar is this, and it calculates the dose of insulin to be delivered for you. So the way that a pump works in terms of insulin delivery, different than the basal bolus regimen where you have a long-acting insulin that you take once a day and 3 doses of a short-acting insulin for your meals. The pump uses only short-acting insulin, and it runs what we call a basal rate as a continuous infusion of insulin for 24 hours a day. And these rates are pre-programmed, and what is amazing about this is that we can alter the rates throughout the day per your insulin requirements. So if you need more insulin during the day than you do overnight in terms of your basal needs, we can set that. We can set the rate a little bit higher during the day versus overnight, compared to taking a one-time dose of basal insulin that then works, essentially the same amount equivalently throughout the day. So here you have a little bit more flexibility, such that if you play soccer and you're going to be at a soccer tournament all day on Sunday, you can actually adjust those basal rates. The bolus part of the pump is that you program the doses that are for the insulin to cover your carbohydrates and your high blood sugar. So again, these are pre-programmed carbohydrate ratios and correction doses. And again, in the pumps, they are called the insulin sensitivity factor for some pumps. The pump calculates your suggested bolus dose based on the settings that we program and the data that the pumper is putting into their pump. And then if you enter into your pump that my blood sugar is X and I'm eating Y number of carbohydrates, it'll calculate a dose and be delivered by the pump on demand by the pumper. There are many benefits to an insulin pump. One, it's fewer injections as opposed to 4 injections a day. You change your pump site usually every 3 days. So you're talking about 1 needle per 3 days compared to 4 a day, or the total of 12 over 3 days. You can achieve more fine-tuned control with an insulin pump, and there are research studies that show that the basal bolus insulin regimen was superior to an MPH regular insulin regimen. And even further, with an insulin pump and the fine-tuned control and flexibility, you can achieve even better glycemic control. There's a lot more flexibility with eating and activity. So as I mentioned, this example of a child who plays soccer, has tournaments all day on Sunday, you have the opportunity then to decrease your basal rates for that tournament. And there's a lot more flexibility also with eating. So if you have a child who likes to snack throughout the day And sometimes those snacks are big and you end up having to give an additional injection of insulin for those snacks. This way, you don't have to do that. You can just tell the pump, I'm eating X number of carbs, and you can enter it into the pump without having to do an additional injection. As I mentioned also, children that have used insulin pumps generally can achieve a lower hemoglobin A1C as a measure of their glycemic control. And further, there are a lot of studies that show fewer hypoglycemic episodes with insulin pumps. Combine that now with closed loop hybrid systems, and you have much less hypoglycemia, and we'll get into that in a little bit. So I just wanted to show this study. This is actually published almost 10 years ago now. But this study actually showed the difference in the hypoglycemia risk between the different insulin therapies that were commonly used at the time. And you can see that in the NPH regimens, there was a greater risk for hypoglycemia. These regimens were very fixed. You had specific meal times, you had specific doses. There really wasn't a lot of flexibility. Then you have basal bolus insulin regimens, where you can see that there was a reduction in the rate of hypoglycemia, 34% compared to 46%. And also, in addition, not even just hypoglycemia, these basal bolus regimens showed actually a reduction in hemoglobin A1C as compared to these prior regimens. And then move forward to the insulin pumps, which is abbreviated as CSII. Here, you also have a further reduction in your risk for hypoglycemia and an improvement in your hemoglobin A1C, specifically when it comes to requiring assistance for hypoglycemia, which is here denoted by these black bars on the bottom. The other important thing to know is that the frequency at which you check your blood sugar is also associated with a lower hemoglobin A1C. And this graph shows you the hemoglobin A1C level on the y-axis, and on the x-axis is your number of blood sugar checks. Now, anybody who uses a continuous glucose monitor, Dexcom, has forgotten probably about the days where we used to check 7, 8, 9, 10 times a day. But you can see that in people who checked more times, they had a lower hemoglobin A1C. So this brings us to the next part of the discussion, which will be led by Maggie West, about different technologies in diabetes that we use both for type 1 and type 2. And I'll turn the microphone over to Maggie.
Thank you, Dr. Wolf. Hi, I'm Maggie West. I'm a diabetes nurse educator here at Johns Hopkins. Dr. Wolf, do you want to have me share my screen, and then I will take it from here. Alrighty, so I will go through continuous glucose monitors, which are an alternative to the self-monitored blood glucoses that Dr. Wolf was talking about. So continuous glucose monitors, also known as CGMs, are wearable devices that use a small wire under the skin to measure the interstitial glucose level, and then they convert that to a blood glucose level. A blood glucose and a rate of blood glucose change are displayed on the monitor, like you can see here on these two screens. And you see those numbers every minute or 5 minutes, depending on the device. The users can also customize alarms to get notifications about high or low blood sugars. So there's currently 3 main devices on the market, but they all work in fairly similar ways. So there's a Dexcom, a Medtronic Guardian, and a Freestyle Libre system. Dexcom and Medtronic have an app where you can view your blood sugars on your smartphone using an app, which is really nice, as long as the smartphone is near the sensor and transmitter. And this way the data can be shared with caregivers that are remote, that are even far away, so that they can monitor blood sugars from afar. The Dexcom G6 and Freestyle Libre do not require calibration with a finger stick, and they're FDA approved for making insulin dosing decisions, which means that together, that means that finger sticks can be replaced by glancing at a smartphone, which compared to testing your blood sugar with a finger stick 10 times a day is huge. So in terms of the effects of continuous glucose monitoring on blood glucose control, use of CGM has been shown to reduce hemoglobin A1C levels without increasing the frequency of severe low blood sugar. Even in adolescents who have historically and statistically the worst glycemic control of all age groups, a recent study showed that using CGM improved their glycemic control when they used CGM compared to the standard blood glucose monitoring with a finger stick. And now the American Diabetes Association actually recognizes that access to CGM should be standard of care for all children and adolescents. So in addition to actually wearing the CGM, the data that we can get from the CGM is very helpful to patients and clinicians when we assess glycemic control. So while a hemoglobin A1C might give us an average blood sugar from the past 3 months, the CGM can tell us about the day-to-day blood sugar patterns. So for example, on this screen, you can see 2 graphs on the bottom, and that tells us about the day-to-day trends. So over an average set period of time, over 14 days, for example, these are what the daily trends in blood glucose are. So we can also use CGM data to assess the amount of time spent in target range. So in the small table above the graph on the right side, you can see the metric called time in range, which is the percent of time that the blood sugar is between 70 and 180. So that's represented with the green bar here. It says 40% in range. There are no specific guidelines for time in range recommendations for children, but to give some perspective, a time in range of 70% correlates about to an A1C of 7%, and the goal A1C for children with type 1 is less than 7.5%. So this can be a really nice way for patients to track their progress to see if their blood glucoses are generally improving over a period of time, while an A1C might not give them as much information. I also like to think of it this way, that you can get to an average blood sugar of 132 in a lot of different ways. You can get there by having your blood sugar between 100 and 150 100% of the time, so 100% of the time in range. Or you can get to an average of 132 probably by bouncing between 40 and 400, which is not healthy. So time in range coupled with these graphs that show us daily trends can capture highs and lows a lot better and will allow us to assess safety. So currently there are no published studies on CGM use in children with type 2 diabetes. As Dr. Wolf was discussing, rates of type 2 diabetes are increasing in children. But looking at studies on adults, in adults, use of continuous glucose monitors improves A1C compared to finger sticks, and also was associated with healthier food choices. We've started to see insurance companies approving CGM in children with type 2 diabetes who are using insulin. But given the rising rates of type 2 in children, this is an area that definitely needs some further research in the future. So to put together this information about continuous glucose monitors with the information Dr. Wolf provided about insulin pumps, these two things together combine to get sensor augmented insulin pumps, which is basically where the sensor is talking to the insulin pump. The most basic type of this system is a low glucose suspend or predictive low glucose suspend system. And in that type of system, the pump suspends insulin delivery when, based on CGM values, an algorithm in the pump predicts low blood sugar in the near future. So the Medtronic 630G was the first pump of this kind, and Tandem has a pump called, or a system on their pump called Basal IQ that was very, very similar to that. So these are just suspending the basal rate when the blood sugar is predicted to dip low. The next type of sensor augmented pump that's a little bit more sophisticated is the hybrid closed loop. So you might also hear that called automated insulin delivery system. There's a lot of words for very similar things. So this kind of pump uses the CGM value to predict future glucose, and based on an algorithm in the pump, either gives a correction dose, increases the basal, decreases the basal, or pauses the basal in order to try to keep the blood sugar in the target range. So the Medtronic 670G and the Tandem Control IQ system are the two systems on the market currently in the US, but they work on different algorithms, although the same concept. With both of these systems, though, you do still have to bolus for carbohydrates. So that's why it's a hybrid closed loop and not a fully closed loop system. It doesn't take away everything, but it does help a lot with these small treatment decisions, and definitely helps the user have to make fewer self-adjustments throughout the day. So I have some data here. Sorry. All right, so this is data related to the Medtronic 670G, which was the first hybrid closed loop on the market. And this pump uses an algorithm with readings from the Guardian sensor. So the above graph is from their pivotal trial of adolescents and adults. This graph is of adolescents specifically. So in this trial, for a 2-week run-in period, the patients wore the pump in manual mode, which means that it was a traditional pump and did not make automatic insulin adjustments. And then after that, for 3 months, they used the pump in auto mode, which means that the pump automatically adjusted insulin based on the CGM reading. So that's the hybrid closed loop feature. So during the time spent using the hybrid closed loop feature, patients had increased time in target range and less hypoglycemia. And in this graph, the gray band and the dotted line show the blood sugars before using the hybrid closed loop when they were using a traditional pump system. And then the purple band and the solid line show blood sugars while using the hybrid closed loop. So the purple band has less variability and less time with hyperglycemia, like we can see in this image. The other hybrid closed loop that's currently on the market is Tandem's Control-IQ, which works with Dexcom G6 and the t:slim pump. And it's been shown to increase time spent in range, reduce the average glucose, and reduce time spent low. So in this graph, on the y-axis is time in range, and then the x-axis is time of day. And then the darker band is the Control-IQ system, and the lighter band is a control, which is just a traditional pump without automatic adjustments. And we can see that particularly in the overnight period between midnight and 8 a.m., users of the Control-IQ pump spent significantly more time in target range, which tells us that this pump works really well to improve blood sugars overnight, and is very helpful for getting a better night's sleep than previously. So these hybrid closed loop systems have really revolutionized diabetes care and definitely allow for improved blood sugars and improved quality of life and less diabetes distress in a lot of instances. But it is worth noting that they're not a panacea, they're not a cure for diabetes, and they do require a significant amount of education on the part of clinicians and families in order to get the most out of their use. So I do have some tips for maximizing therapy with hybrid closed loop. I think that over time, the diabetes community is going to come up with more clear guidelines on best practices. But again, patient education is really important. So firstly, while hybrid closed loop significantly reduces hypoglycemia, lows will still happen sometimes. And it's important to remember that the pump might have had the basal rate suspended or decreased prior to the patient treating the low. So the blood sugar might be on the upswing at the same time as the patient's treating the low. So it's possible that 15 grams of carbs is a little bit too much to treat the low blood sugar and could cause hyperglycemia. So consider treating low blood sugars with slightly fewer carbohydrates if the patient's noticing rebound hyperglycemia. And the next recommendation is not unique to hybrid closed loop, it's to bolus before eating. We know that in the majority of cases, insulin works best when given 15 minutes before a meal. But in hybrid closed loop, if the patient doesn't bolus and the blood sugar starts to rise when the food begins to absorb, the pump might contribute some additional insulin in the form of a basal rate or an automatic correction dose. So by the time that the patient boluses for the meal, they have 2 insulin doses going from the increased basal or correction and the food bolus. So that could lead to hypoglycemia in those cases. So it's just an extra reminder, extra incentive to bolus prior to eating. Similarly to that, reminding patients not to override boluses, particularly corrections. So hybrid closed loops might recommend slightly different amounts of insulin than the patient is expecting from their old system, and that can make it enticing to manually increase a recommended correction dose, but the system works best when you let it work. So the pump might have been running an increased basal rate for a couple of hours prior to when the patient wants to give a correction. So if a patient manually increases their correction dose, they're effectively stacking their insulin and can definitely end up with hypoglycemia. So a reminder to them to just let the system do its work, and if they need to work with their medical team to adjust settings, they can do so. So both of the these systems on the market, the t:slim and Medtronic, have some settings that can't be customized to the patient. So that may mean that the medical team needs to adjust some settings in order to respond to patterns and bring blood sugars into target range. And then lastly, because you can't set temporary basal rates on either the Medtronic or the t:slim in hybrid closed loop, the patients might need to use some of the pump's features to change the target based on their expected activity. So t:slim and Medtronic have similar systems in having this work, but in t:slim, there are 3 different modes with slightly different parameters for adjusting the basal rate. So there is a sleep mode where there's a tighter target range, and there's an exercise mode where the target blood sugar is higher. For example, that could be used if a patient is going to be exercising or in a small child that may want slightly higher target blood sugars. Looking towards the future, there are definitely some exciting advancements coming down the pipeline. So we were just talking about inability to adjust targets outside of these pre-programmed modes, but this is something that in the future we might be able to do. We may be able to personalize the algorithm a little bit for different patient needs, such as a higher target for an infant or for an athlete who's preparing for sports. Hopefully in the very near future, we'll be able to control insulin pumps from our phones. This is probably not too far away where we'll be able to deliver a bolus from a mobile app. t:slim actually says that they're going to be rolling out with the quote unquote mini pump, the t:slim T-Sport pump, which is on the right, which is a much smaller pump and would be run from a phone. And then in 2021, hopefully we'll see Omnipod come out onto the hybrid closed loop scene with the Horizon system, which will be a different algorithm from Tandem or Medtronic, but a similar concept, where the Dexcom would be integrated onto the Omnipod Dash PDM or onto a smartphone, and this would give users an option for a tubeless hybrid closed loop pump. So all of these things looking towards the future for FDA approval, hopefully sometime in the future. And then lastly, even further in the future, we're looking at development of do-it-yourself systems. So a background on that, patients kind of broke into commercially available insulin pumps and continuous glucose monitors and use open source software to create their own hybrid closed loop algorithm operated from a phone. Of note, none of these have been reviewed by the FDA, so they're not approved for use by any means. But in the future, a company called Tidepool plans to submit one of these apps to the FDA for potential approval for another option for patients. And then I think the goal for everybody, the ultimate goal of device development, is the bionic pancreas. So this has currently been in investigation by a company called Beta Bionics. It's been in the works for a long time, but the end goal is to have a device with both insulin and glucagon, and those 2 hormones would be delivered depending on blood sugar patterns. And in theory, the user would just enter a weight, and then the pump would take it from there, and we wouldn't have to bolus for carbs, we wouldn't have to adjust doses, the pump would just do the work for us. So that would be the true bionic pancreas. So looking at the past couple of years of diabetes care, technology has advanced at a very rapid rate, especially thinking back to the time of testing blood sugar using urine sticks. And a fun fact is next year is, I believe, the 100-year anniversary of the discovery of insulin, which is amazing. And this month is Diabetes Awareness Month, so some things to celebrate. So thank you very much for listening. And I believe we have some time for questions.
So I'll get started with one of the first questions that's come in, which is, if one child has diabetes, do you recommend testing for other siblings? So this is a common question that we get from our families about whether other children in the family should be tested for diabetes. Now, when you have a sibling with diabetes, your risk of developing type 1 diabetes is a little bit higher than the general population. But we don't actually recommend just checking routinely to see if they have diabetes, but there are options for testing as part of studies. So the TrialNet study, which has been going on worldwide for many years now, has enrolled over 175,000 patients who are siblings or family members of people with type 1 diabetes to look at the rate of antibody development for type 1 and at what rate they develop diabetes. So that is an option for families if they want to do it through a research protocol where they can be followed, and if there is any indication that another child has antibodies, they can undergo further testing through the study. You can also ask your pediatrician to order lab tests, which would basically be doing a screening hemoglobin A1C and antibody levels on your other children, but it's actually not generally recommended by endocrinologists. So those are just a few options, though. Maggie, do you want to take the question on exercise?
Sure. So we have a question, how does exercise play into pumping? This is thinking about a child who experiences insulin sensitivity after hockey practice. So it's very common for children to need different amounts of insulin based on activity. So there are a couple of options depending on what treatment you're using. So you could talk to your team about a temporary basal rate for after sports, considering that might help. If you're using a hybrid closed loop like t:slim, you could leave the exercise mode on for longer is another idea. And then snacks are also another option that work well probably after activity when someone might be hungry. So pumps are really, really helpful for exercise though, because you can adjust the settings. Even if you're using a hybrid closed loop that's not completely adjustable, we can figure out ways to make it work given different levels of activity.
And the only other thing I would add to that actually is thinking about the big picture when it comes to exercise, pumping, and diabetes management is also speaking with your diabetes center nutritionist who can also talk about ideal snacks in the setting of exercise. So thinking about foods that not only have a little bit of carbohydrates, but also have some fat and protein, which will help keep the blood sugar elevated longer versus a rapid acting carbohydrate that might help you bring it back up, but will come back down more quickly. So again, thinking about the comprehensive big picture, that's another opportunity to engage a nutritionist and help with exercise. We have another question about what are our thoughts on different insulin pumps, and specifically the question is about an Omnipod insulin pump. So I think I'll just speak to the difference in that there are several pumps on the market. The only tubeless pump on the market currently is the Omnipod insulin pump. All of the other pumps that are on the market have tubing, meaning that they are connecting the actual pump device where the insulin is held through a small tube that then is inserted under the skin in a subcutaneous fashion versus the Omnipod, which is just tubeless. And I showed some pictures of the differences there. The pumps in general and how they function are all fairly similar. Their insulin delivery generally ranges from every 3 to 5 minutes of delivery, meaning that they just give a little spit every 3 to 5 minutes. For the basal rates, but the settings that you can establish on the pumps are all very similar in terms of your basal and your bolus. So really the difference there is whether you want a tubed pump or a tubeless pump, and then what technologies are available with that pump vary by who's received FDA approval for their closed loop or their hybrid closed loop system. So right now, Medtronic and t:slim both have hybrid closed loop systems that are FDA approved on the market. Omnipod is about to launch their Horizon system in 2021, and they will have their hybrid closed loop system on the market as well. So it's really just it's been a temporal trends of time of, the first one was Medtronic, then came t:slim, next will be Omnipod, and they'll all have a system on the market, and then you have to just decide if you want tubed or tubeless.
I would say if you have a child who is a competitive swimmer or spends hours and hours in the pool, consider that there are certainly ways to manage swimming for long periods of time with disconnecting a tubed pump, but those patients are the ones that I feel like I've seen have the hardest time with a tubed pump, and who should potentially consider the benefits of a tubeless pump, given that the technology is moving in the same direction.
So the next question is, at what age will my child see an adult specialist for diabetes? So this is a really good question, and this is actually an area that Maggie and I are quite interested in, as we actually hold a diabetes transition event for our patients who are going off to college and considering transitioning to adult diabetes care. And we hold that event every March. And we've been doing that for the last few years, and it's a really fantastic educational experience. And it's very short, Sunday morning, 2 hours, with some education and then a panel discussion by some of our patients who have recently gone off to college and have come back to share their experiences in that transition process. But generally, it depends per practice. So some pediatric endocrinologists see their patients through age 18, others through 21, some even longer. And I think it also depends on the capacity. Pediatric endocrinologists are not as far spread out and available in other areas as our adult endocrinologists, because there are many, many more adult endocrinologists. So if you are a family that lives on the eastern shore of Maryland, and right now you're driving into Baltimore to see your pediatric endocrinologist, although right now we have some telehealth opportunities, which hopefully will last into the future. You know, if that's the case, you may want to consider transitioning around age 18 versus waiting the extra few years. I think one of the other big differences, though, is that in pediatric diabetes care, the current recommendation is to see your diabetes providers every 3 months. And there's a lot of additional resources that are generally offered through a pediatric diabetes center as opposed to an adult endocrine office. So in our center in particular, and very similar to the other programs in Baltimore County, is that while in addition to seeing your pediatric endocrinologist, you also have the opportunity to see a nurse or diabetes educator. Like Maggie. We have nutritionists who are part of our program, and you can see them at every visit if you would like. We also have behavioral health or psychology integrated into our program, such that those transition moments where there's a lot of stress, or even, you know, starting kindergarten or transitioning to high school, all of these things carry a lot of distress on top of the regular, and what we know exists in diabetes is the typical diabetes distress or even depression that can exist in the adolescent years. So making sure that we, you know, provide that comprehensive care is very important in pediatric diabetes, and it's still important in adult care, but a lot of those appointments would be done separately versus at one time in the pediatric center. So those are things to think about. And, you know, for type 1 diabetes, generally it is managed by an endocrinologist. However, type 2 diabetes is often managed in the community by primary care doctors. So an adult with type 2 diabetes, or if you have a child with type 2, although we do know that there are differences between pediatric type 2 and adult type 2, that can be managed by an adult primary care doctor.
So here's a question about feeling overwhelmed with a recent diagnosis with type 1. So someone's expressing, I'm nervous and overwhelmed by the new technology and information on how to take care of the child. So I would say, remember that diabetes is a marathon and not a sprint. Remember that when you're diagnosed with diabetes, everything about the life of the whole family changes. So there's no right or wrong time to start technology. I think as diabetes professionals, we get excited about the technology, but there's also no right or wrong way to do it. And if the technology is too much in the beginning, then that's not going to be a net gain for you anyways. But if it is something that causes additional stress, additional worry, or trauma for the child, then it's potentially not worth it at that time and should maybe be explored later. So my best advice for newly diagnosed folks is to kind of take it week by week, or even day by day, and not think too much about what needs to happen or what should happen, because we want everyone to have access to pumps or CGMs, but they're not always right for every child at every time. So it's not necessary to start technology if you're not ready. I think just work with your diabetes team on when is the right time to use it, and focus on the basics, and then you can move on to pumps and CGMs if you feel like it's a good fit later on.
So the next question we have is about pre-diabetes in children. And the question is, how long can my child be pre-diabetic? And is there anything I can do to prevent the progression? So this is an excellent and very timely question. As I mentioned earlier in the talk, type 2 diabetes in pediatrics was not something we really saw that much 20 years ago, but now we are seeing a lot more of it. And as a prelude to type 2 diabetes, we often see what's called prediabetes. This means that you have a hemoglobin A1C that is between the range of 5.7 and 6.4. So we say you have a diagnosis of diabetes when your hemoglobin A1C is over 6.5%. But when you're in that prediabetes range of 5.7 to 6.4, it's called prediabetes. And what we do know about this is that it's much more common now. It has generally been coincident with the obesity epidemic, so being overweight and having other risk factors for type 2 diabetes. And we tend to see more of it in the adolescent pubertal age because of the inherent pathophysiology of our bodies, and that we have more insulin resistance, meaning that our body's insulin needs change during puberty. So sometimes children will become pre-diabetic during that range, but there is actually sometimes a regression after puberty is complete. Now, in terms of what the progression may be for prediabetes, so we take prediabetes very seriously. We always start with lifestyle modification and dietary nutritional interventions to try and improve the lifestyle, making sure that we're exercising, eating a healthy diet, and there's a lot of recommendations specific to those initiatives. But what we do know is that children who have a hemoglobin A1C under 6.6%, so on the lower end of that prediabetes range, are less likely to progress to type 2 diabetes than children who have a hemoglobin A1C that's over 6% and below that 6.5% of diabetes. So when we get into that 6 to 6.4% range, we tend to be a little bit more aggressive in terms of our management, which again really starts off with lifestyle modification. So anybody can start that, anybody can discuss that with their primary doctor, and that's a really good place to begin. But if the A1C does creep up to over 6%, definitely recommend seeing an endocrinologist who has the resources in the clinic setting to address some of the nuances of nutrition, healthy diet, and lifestyle modification. So working on that to prevent the progression is really important. If the child is overweight or obese, trying to get them out of that range and into a healthy weight area.
So the next question is about the pandemic. I'm worried about bringing my child in for care during the pandemic. Is it safe? And are we offering virtual consultations? So we do a lot of virtual visits right now. We recommend generally that people are seen in the office every other time during the pandemic while this is occurring, so that the physician can do a physical exam, height and weight and blood pressure, and we can do the hemoglobin A1C. And different attendings with our group will have different guidelines for when they want to see someone in person. It's kind of on a patient-to-patient basis, but we do a lot of telemedicine. In terms of in-clinic, we have a lot of safety mechanisms in place. So limiting the number of people allowed in the building. Everyone is required to wear a mask in the building. All of the clinicians and staff are required to wear a mask and face shield anytime we're near patients. And then we're trying to get patients back to the waiting room even faster than usual. We're also doing a lot more cleaning than we did previously, given COVID. So we're taking a lot of precautions, knowing that COVID is changing a lot. So we don't know what the future will look like in terms of how many of our appointments will be virtual versus in person over the next couple of months. We'll have to all stay tuned for that. For question 9, I am hesitant to learn new technologies because I'm not sure I'll be able to use them. Is there everything easy to use and are trainings available? So for our office, what we usually do and what is pretty common is the patient will decide on a pump. I encourage you to work with your endocrinologist or diabetes educator on considering the pros and cons of all the pumps, because as you probably learned today, there's a lot of different nuances to each system that might work well or be difficult for each family. So work with them on deciding on a pump. And then once you decide on a pump, obtain the pump from the pump company. Generally, a trainer from the pump company will do a visit with you. Usually that visit is an hour to 2 hours. It is sometimes done virtually, and you really run through the nitty-gritty components of the insulin pump and how to use it. And then for a week, you wear the pump. The child wears the pump with saline in it, so just water, and practices wearing the pump, using the pump, except there's no insulin in it. So you're doing kind of a dry run, practicing the buttons, changing the infusion sites, everything before you actually start the insulin. And then a week later, you meet with someone from our team to do the insulin start. So we watch you put insulin in the pump. And then after that appointment, we talk on a daily basis for about a week in order to get the doses right. Sometimes when you start a pump, you need to adjust the doses a little bit. So the long and short is after you start technology, we do a lot of communication with families to make sure that they're on the right track. There are always questions. Everybody has a lot of questions, and there's a lot of scenarios that you can't anticipate until they happen. So things that you have to troubleshoot a little bit. So for pumps, that's kind of how we bridge between multiple daily injections and insulin pumps. And then similarly for continuous glucose monitors, we offer a meeting with the diabetes educator to place the sensor if you'd like, and we can go through a lot of the education components there that are important to know. And then Dexcom, I know, has a line where you can reach an educator during the day if you have clinical questions regarding their device. And I believe Freestyle and Medtronic probably have something pretty similar. So there is a lot of support for the devices. They're easy to use, but at the same time, there's a lot of little nuances that can pose problems, and there's a lot of people to help with those. So
I love the next question. I have heard the type 1 diabetes community is very close. How can I get involved with my child? So I think this is a wonderful question, and it is true. The diabetes community is very close. I think the biggest resources are the Juvenile Diabetes Research Foundation, and you can look up their website. They have a lot of activities. They actually have a lot of virtual activities going on throughout the year for children with diabetes. They have opportunities to become involved in some advocacy work for the kids. Usually every year there's a gala that they do, and the kids get to be ambassadors and attend the gala, and it's really fun. And then the American Diabetes Association also has a lot of activities, resources for children. There's a walk by each of these organizations every year, which is really fun to attend. I mean, this year they're all virtual, of course. There are some Facebook sites that people enjoy. So for people who have young children with diabetes, there's Diabetes in Diapers. That's just a Facebook site. There are several of them, so definitely ask a friend who has type 1 diabetes. I think the other thing I would say about that is that no child should really be alone in this, and that there are a lot of other children either at their schools or through people that you might know, and having somebody to talk to about it, to share experiences on what pumps and technology they're using, or just what it's like to go to school with diabetes for the first time, or I guess virtual school with diabetes for the first time. Some of these things are really well discussed, amongst children, and the GDRF has a program for connecting families together. So I would definitely consider reaching out to them. The other thing I love talking about is diabetes camping. Maggie's smiling because she knows I love this. So diabetes camps are a really wonderful way for children with diabetes to meet each other, to spend time together, to share their knowledge, and to learn about managing diabetes. These camps, we actually have 4 diabetes camps in Maryland. 3 are sleepaway. 1 is a day camp. We run the day camp that is in Maryland. It's a joint effort with the American Diabetes Association. It's called Camp Charm City. It's for young kids ages 5 to 12 with CITs ages 16 to 18. And it's just really a fun way to go to camp, have a lot of medical supervision. So that reassures parents. We have a huge medical staff watching the kids all day, and a lot of awesome counselors who make sure they're having a blast as well. So there really are a lot of opportunities to get involved, and I would strongly encourage that for anybody, especially with a family who's dealing with a new diagnosis, the support is really tremendous. Maggie, I don't know if you want to add to that.
The only other organization that I'm thinking of is Children with Diabetes is the last organization, and they yearly in Northern Virginia have a conference called Friends for Life, and they have a yearly big, huge conference, obviously not this year, in Florida, which is a huge gathering of people. So yeah, there's a lot of resources. It doesn't end when you get older with diabetes, but it's really good to find people that are similar to you and have some of the same challenges. So I also encourage that.
And not to mention, not only for your children, but also for parents to have other parents to talk to about, specific challenges that you might experience. So the next question we have is related to nutrition and carb counting. And it says, regarding carb counting, sometimes I feel like the insulin dosing doesn't always match the total carb amount on the food label, provided even when it's followed as accurately as possible. And is this related to how carbohydrates are absorbed? So this is a really good question. I will share the disclaimer that I'm not in nutrition, but I have a very big interest in nutrition and how it relates to diabetes. I think your question addresses several different points. That one are insulin sensitivity and our strength of our carbohydrate ratio definitely varies by the time of day. So that might be one thing, and that, a lot of children do have different ratios for different meals. So that could be part of it. The other thing to consider is that the other things that are included in the carbohydrates. So number one, what's the glycemic index or the glycemic load of the carbohydrate? So different carbs have different glycemic loads, meaning how high and how rapidly they raise your blood sugar when you consume them. So the glycemic index is a really important component of nutrition. And there actually are ways to balance it out with lower GI or glycemic index foods that the nutritionist who's part of your clinic could address. The other thing is sometimes the way that you share or match your carbs with proteins and fat will change the time it takes for them to be absorbed. So generally, if you add protein and fat, it slows the absorption of your carbohydrates. Or if you have a lower glycemic index food, it will not raise your blood sugar as rapidly or as much. So there definitely are a lot of nutritional components, and that's why the nutritionist is so critical in the daily diabetes management and thinking about the foods that we eat on a daily basis.
I will also add, working with your CDE, who could be a nutritionist as well, about the potential for on a pump using an extended bolus for foods that have a high protein or fat content can help match the carb absorption to the insulin absorption. And then yet another plug for giving insulin prior to eating. So ideally 15 minutes before eating, but as much as possible before eating and instead of after the meal. A high school age child is looking for a new doctor. Should they see a pediatric or adult specialist? So this depends. I don't have a straight answer, unfortunately, on what your child's needs are. If they want to see a team that has a nutritionist, a diabetes educator, psychology, all in one, you're probably going to have more luck with a pediatric team. If your child really doesn't want those things, then an adult team might be a better fit. But just know that for a lot of kids in the transition years from in emerging adulthood, even if they may not think that they want to see a psychologist and nutritionist, they're probably helpful in a lot of ways because those years can be really tough during emerging adulthood. So my opinion is that more support is usually better during those years, but at the same time, a lot of things come into play, like location and availability of people. Adult providers do tend to just be a bit more hands-off. Do you have anything to add, Dr. Wolf?
Well, I think that actually brings us to our last question of the morning, which is, as my child has gotten older, I've had trouble encouraging them to take ownership of their own health. How can I stress the importance of this to them? This is a very challenging question, and I think it speaks to some of the resources that a pediatric endocrinologist and team can provide, really with the addition of the psychology component in the clinic setting. And most pediatric diabetes programs, at least in our area, do have this as part of their program. Taking ownership is really important in the sort of emerging adult years, as Maggie alluded to. Having the motivation and providing some motivational interviewing to help them assume some of these responsibilities is really important. So one of the things that we do to address this is, starting at the beginning of high school, we actually go through a list of tasks and we try to help the child assume some of those tasks from their parents. The other thing our psychology team does is they have like a great program for figuring out what age is appropriate to take over a specific task and help the child find things that they feel are feasible for them to take ownership of. So I think it's really a bigger conversation with your team, with your behavioral health or psychology specialists, to see like what the child is able and willing to take over. Obviously, some are more motivated than others, but I think the team approach can really help with this. And one of the things that we struggle with in this age group particularly is that, the children just don't want to be nagged by us. So sometimes it's actually better if it's coming from the doctor or the health team provider versus the parents. So it's not like the parents like nagging them to do it, it's us who's nagging them, so you can blame it on us. And we're always happy to take that responsibility. So that might be another way. And, most programs do have the psychologist, and they usually are available either in person or by telehealth. And I think, really setting a goal of meeting with them once a year, especially during those transition years of high school into college, is really, really important just for the overall health and well-being of the child and the family together. I think that wraps up our session for today. Thank you for all of your excellent and engaged questions, and Maggie for all the discussion on the technology. We really appreciate you joining us today.
Thanks, everyone.